Hi, and welcome to today's program of 4D. Uh, the whole program consists of detailed discussion about and dialogues in diabetes when specifically for our Indian population. And today's episode is episode 21, and we're already in season 2. It is a very important aspect when we have to have these dialogues because diabetes is a big challenge for all of us. And as treating doctors or as individuals dealing with diabetes, it's important that we are able to educate everyone with the right knowledge in order to fight this big challenge. Today's topic will be to discuss about diabetic foot and diabetes. And today we have Dr. Pranab uh, Patik from. So it's a great honor uh, to introduce Dr. Pranab, and he has done his MBBS from Guwahati Medical College in 2006. He's done his postgraduate diploma in diabetology. He has his fellowship in diabetology done in 2018. He has a varied interest in gestational diabetes as well, and he's a certified trainer in National Diabetic Educator as well. He has total 14 years of experience, 6 years as a practicing consultant diabetologist, and he's been part of many programs, and he's also conducted clinical research trials. He's been a co-investigator. He has a vast knowledge when it comes to diabetes, and I think he's the right person for us to take this topic forward. Over to you, sir.
So thank you for your kind words of introduction, and it is a real pleasure to be a part of this program. And without wasting much of our time, I'll directly go to the topic that is entrusted to me for tonight's talk. It's basically about diabetes and foot complications. Yeah, can we have the slides on the screen? So we all know that a lot of patients who suffer from diabetes invariably have some sort of the other foot complications, and most of the time these complications increase in severity and they flare up, especially when adequate amount of foot care is not taken care of. We know that foot is the vital organ of the body which supports the entire, bears the entire weight of the body. But as a physician and as a diabetologist, it's very necessary to educate the people or to increase the global awareness about foot complications which can arise in uncontrolled diabetic patients, or for that matter, any diabetic patients can end up with foot complications if adequate and timely foot care and proper footwear is not worn. Next slide. Now we know that the growing burden of diabetes has been increasing, and the prevalence is attributing to around 9.6% of the adults who are aged 20 years and above. Now there's no special age for diabetes. Anyone can end up with diabetes at any point of time. In India, 1 in 11 adults is living with diabetes. The number of people with diabetes is second highest in the world. We know that India is a diabetes capital. And over 53.1% of the adults living in diabetes remain undiagnosed. So that really is a very gloomy picture. We know that 90 million adults will be living in diabetes, and 1 in 2 adults with diabetes remains undiagnosed. Now, of course, the awareness about diabetes has increased, and gradually we are picking up more and more undiagnosed patients. 747,000 deaths are caused by diabetes in the year 2021. So that's a big number. And if adequate and timely intervention is not taken care of, then in the years to come, I think these numbers will exponentially increase, which will increase the burden of diabetes, and at the same time, timely intervention is very much required. Next slide. Now, we all know that most of the patients in whom the glucose target hemoglobin or HbA1c persistently remains on a higher side, they'll end up with various complications, both microvascular and macrovascular complications. Since tonight's talk is focused mainly on diabetes and foot complications, I'll try to keep my agenda straightforward and focused on these foot complications which can arise because of these uncontrolled diabetes. Now, prolonged hyperglycemia can have a lot of diabetes complications, and these are associated peripheral neuropathy, peripheral vascular disease, foot ulcers, high risk of sepsis, poor wound healing, and most importantly, the last stage or the most sad part of the story when the patient needs to ampute a part of the limb or the entire limb, that really is very agonizing. So limb amputations may also be required in severe form of the disease. Now, diabetic neuropathy often leads to development of diabetic foot ulcers. Up to 1/3 of diabetic patients may suffer from diabetic foot ulcers at any point of their time. And that is why I have always advised my patients to take special care of their feet, because the feet deserves as much attention as the other organs of the body. Foot ulcers accounts for 7 to 11% of all the hospitalized admissions in diabetic patients, and it is very necessary that whenever any foot ulcer is detected, we need to take timely intervention, otherwise they can progress. Next. Now, epidemiology of foot complications in diabetes, in the family or journal of family medicine and primary care, there has been a lot of papers which have been published where it is necessary that educating the patients about the diabetes foot care is of paramount importance, and the global prevalence of diabetes will increase from 1.6 to 8%. Diabetic foot ulcers are more common in men than in women, especially with type 2 diabetes than type 1, because type 1 invariably is present in the children. And the high risk and high incidence of these diabetic foot ulcer and the recurrence rate keeps on increasing, and the value reaches 40% within 1 year, and it exponentially increases to 65% within 3 years. So that is why we see that all these foot ulcers needs special and timely intervention. Now, diabetic foot management is basically an integrated approach where we need to identify these risk factors for diabetic foot ulcers and treat the risk factors so that in future these foot ulcers can be prevented. And any ulcer should not be neglected, because sometimes what happens, the ulcers will worsen, will increase in size, and eventually it may lead to amputation. That again is very much agonizing for the patient. Next slide. Now, based on the classification and staging on the natural history, it can be classified as 1, 2, 3, 4, 5, 6. 1 is normal, second is high risk foot, third is the ulcerated, grade stage 4 is cellulitis, stage 5 is necrosis, and stage 6 where there is a requirement of major amputation. Now, Wagner's classification, which we all know, is one of the most important classification to understand the severity of diabetic foot ulcers, and grade 0 to 5 it is, and grade 0 is intact skin where there's an impending ulcer, grade 1 is superficial, then grade 2 where deep to tendon, bone or ligament are involved, grade 3 where it touches the bone, then there is involvement of osteomyelitis where you need to sometimes do the probe to bone test to identify these risk factors, then grade 4 gangrene or loss of the toes or the forefoot, and the grade 5 is the gangrene of the entire foot. So we have to, whenever we get in diabetic foot ulcers, we have to grade, and then we have to understand which stage of the disease, so that accordingly the treatment modality will change. Next slide. Pathophysiology of diabetic foot ulcers. We all know that the most important reason is prolonged hyperglycemia, where there is a collagen cross-linking disorder, then the cell defense disorders, inflammation, decreased inflammatory response, and disrupted angiogenesis, which ultimately will result in impaired or defected wound healing. Then diabetes mellitus patients will suffer from diabetic peripheral neuropathy. It can be sensory, motor, or autonomic, where in the sensory there is loss of protective sensation, motor there is a bone deformity, and autonomic where the skin is dry, there is no sweating or decreased sweating, there may be development of fissures. And peripheral arterial disease also requires much attention, such as atherosclerosis, increased oxidative stress and inflammation in the lower limb, microcirculation ischemia. So all these can coexist, or they can be said that it can occur individually also, and all these are considered to be important attributing risk factors for promoting and development of diabetic foot ulcers. So we have to understand the pathophysiology, because every patient is different and may have different pathophysiology, but these are some of the common predisposing factors and pathophysiology which attributes to increased chances of diabetic foot ulcers in the patients. Next slide. Now, diabetic foot risk classification, urgent priority or active pathology, where there is an open wound or an ulcerative area with or without signs of infection. So timeline is immediate referral consultation is required and suggested follow-up as determined by the specialist. There may be new neuropathic pain or pain at rest, signs of active Charcot deformity and vascular compromise. Then high, there is a ADA risk category 3, where there is a diabetic foot in remission, in which there is presence of diabetes with previous history of ulcer or lower extremity amputations. There may be associated chronic venous insufficiency, where there is skin color change or temperature difference, and timeline is it may be an immediate or next available outfill department, and suggested follow-up will be required every 1 to 2 months. Moderate ADA risk category 2, where there is associated a development of PAD and loss of protective sensation, and the pulses may be diminished, the distal pulses can be diminished, and most importantly, there may be presence of swelling or edema. This requires timely referral within 1 to 3 weeks and suggested follow-up every 2 to 3 months. Now, the risk or the priority may be low AD risk category 1, that is where there is a long-standing, non-changing deformity, and the patient requires prospective or accommodative footwear, and there should be a referral within 1 month. And these are the patients who needs to come for follow-up every 4 to 6 monthly. And very low, which is known as the AD risk category 0, where there is no loss of protective sensation or peripheral arterial disease, and the patient seeks education on topics such as routine foot care. So very low AD risk category 0, where there is no loss of protective sensation or peripheral arterial disease, and the patient seeks education on topics such as routine foot care, authentic training, appropriate footwear, or injury prevention, which again requires time and consultation, referral within 1 to 3 months, and at least annually these patients should be followed up. So if we understand that, so this diabetic risk, foot risk classification has to be done, because based on this risk, we can categorize the patient's treatment, patient's follow-up, and what we can understand is the severity of the patient's foot ulcers and how we can tackle that problem. So that is why this foot risk classification is very much important. Next slide. Now, therapeutic strategies for diabetes management. First of all, we know that early combination therapy is very much required, and it's an approach to achieve the glycemic goal and delay the prevention of complications. And most importantly, it delays the deterioration of glycemic control with possible better preservation of beta cell function. Because we know that by the time a patient is diagnosed with diabetes, roughly around 50% of the beta cells get depleted. And over a period of time, as the duration of diabetes increases, there is further deterioration of the beta cells. So our aim is to preserve the functioning beta cells. Now, novel medication therapy is that they are used with diet and exercise. We know that lifestyle modification, it has to be done for each and every patient. We need to control the blood sugars in adults with type 2 diabetes, and there will be different modalities of treatment. We have different armamentarium of drugs. Amongst these, which deserve special mention, such as DPP-4 inhibitors, which include sitagliptin, saxagliptin, linagliptin, allogliptin, SGLT2 inhibitors, which have revolutionized the entire treatment of diabetes, and are now no longer considered as for treatment of diabetes alone. They have got so many extra glycemic benefits, such as cardiac benefits, renal benefits, and therefore they are used, and they're very important for diabetes management, which includes canagliflozin, dapagliflozin, and empagliflozin. Then GLP-1 receptor agonists, such as glucagon, like receptor 1 agonist, regulates and restores the incretin function. So we have to understand this novel medication therapy and give to our patients as and when required, in combination or maybe sometimes as a single drug, and as and when required, we have to modify the doses also. And this novel medication therapy is very important to keep the good glycemic control and to have a beneficial effect on the patient's glycemic status and reduce the chances of complications. Next slide. Now, the newer molecule, as I've already said, that the SGLT2 inhibitors, which have revolutionized the entire management of diabetes. DPP-4 have been there for almost more than a decade, and many patients will require the combination of these two. We know that metformin has been used and remains the first line of drug of choice, but now we can use any molecule even with this as a first line therapy. The SGLT2 inhibitors, they are considered to be the newest anti-hyperglycemic class, which inhibits the renal glucose reabsorptions, and they will produce glucosuria, they will promote weight loss, and they will also have a beneficial effects on the blood pressure, though a small reduction of 4 to 6 millimeters systolic and a small reduction of 1 to 2 millimeters diastolic blood pressure can be seen with the SGLT2 inhibitors, and they have got low risk of hypoglycemia. DPP-4 inhibitors can be used, and they, as I've said, that they've been there for more than a decade. It inhibits the GLP-1 and GIP. It stimulates the insulin secretion for the beta cells. It inhibits the glucagon secretion from the other cells, and they are weight neutral, and there's also low risk of hypoglycemia. They have got different modalities of action, different mechanisms, and synergistically they will act together to make a beneficial effect in reducing the HbA1c. SGLT2 inhibitors will increase the glucosuria, increase the beta cell sensitivity, increase glucagon. On the other hand, DPP-4 inhibitors will have an increasing effect. They will increase the GLP-1, GIP, they will increase the insulin secretion and decrease the glucagon. The net effect of both of these combined together is that there will be reduction in the blood glucose level or decrease hyperglycemia. Now we know that SGLT2 inhibitors have some additional beneficial effects of promoting weight loss and small reduction in the blood pressure. So SGLT2 inhibitors With a DPP-4 inhibitor, fixed drug combination is therefore considered to be a suitable option for Indian type 2 diabetic patients for the following reasons: because they are very safe, they've got rapid and sustained glycemic control, they will improve the insulin resistance, which is a very important factor to be addressed in type 2 diabetic patients, and most importantly, they also help in preserving the beta cell function. They will reduce the body weight, they will have a beneficial effect on reducing the blood pressure. These are extra glycemic benefits. Most importantly, we know that it will reduce the pill burden, so there will be better adherence, better compliance, which will have better clinical outcome. And in a country like India, where cost also matters, these combination therapy or fixed drug combinations are very cost effective. Next. Now, there have been studies which have shown that dapagliflozin in combination with sitagliptin was well tolerated and led to clinically meaningful reductions in the glycemic parameters and body weights that were sustained throughout 48 weeks of treatment. You can clearly see from the graph. The HbA1c reduction was good, and the patients who were put on this combination therapy, they had better glycemic control, better reduction in the HbA1c after 48 weeks of treatment, and most of them were tolerating very nicely. There was no adverse effects, so it was very considered to be safe combination of dapagliflozin with sitagliptin. Next slide. Now, benefits of DPP-4 inhibitors. We all know that wound healing effects of DPP-4 inhibitors, an emerging concept in management of diabetic foot ulcers, which have been studied, and there's been papers which have been published, and it has been shown that DPP-4 inhibitors improve the wound healing of diabetic foot in 3-month randomized trials. They've got a very promising effect in the local wound healing of diabetic foot ulcers, in addition to its already established glycemic control. So patients who are given these DPP-4 inhibitors, they will get the benefit. They can be treatment better of these diabetic foot ulcers and infections, and they is very effective in controlling the blood sugar and helps in wound healing. Next slide. So I think this is all in a nutshell about these beneficial effects, and we have seen patients taking these fixed drug combinations which have got so many beneficial effects. Now, glycemic and extra glycemic benefits are also there, which are beneficial for the patients. And as I've said in the beginning of my talk, that foot care deserves special mention. That is why taking timely foot care, and if any ulcer is there, it should not be neglected. And diabetic foot ulcer management is an integrated approach where sometimes we have to take the help of a podiatrist, we have to take help of a surgeon, we have to assess the vascularity. So all these factors have to be given care of. And most importantly, educating the patients about the importance of diabetic foot can really control and prevent future diabetic foot ulcers and diabetic foot infections. On the diabetic foot related complications can be prevented if we take timely intervention and take care of the feet in a proper manner. Thank you.
Thank you, Dr. Pranab. I think it was amazing to hear you speak today, and I think a lot of us are going to be more enlightened with what you have shared, the knowledge that you have shared. So we have a couple of questions. Most of the questions have already been covered. So just to highlight a few points, just what you have already spoken. And I think, let's get the focus back on primary risk factors of, what these foot complications could lead to. In your opinion, how do we, when we are dealing with diabetes, there's so many other factors that are playing a part, and especially when it comes to the foot. What is your approach when it comes to, taking a look at individuals who have these foot complications, and how can we manage these complications to reduce that risk of foot ulcers?
Now, there are some primary risk factors which are associated with foot complications, and most importantly, first of all, whenever we get patients with these diabetic foot ulcers, what we assess is, first of all, the glycemic status, because unless and until you have a good glycemic control, it is not possible to prevent these foot-related complications. Now, some patients may also have foot deformity, clawing of toes, hammer toes, so there may be these kind of risk factors which are present, and additionally, these may be anatomical deformity. Then it is also necessary to keep in mind that sometimes what happens, there may be callus, corn, which often remains untreated, and these can invite the development of ulcers. So foot inspection and proper foot examination is of paramount importance, because unless and until you examine the feet, only by asking the question may not be enough, because patients may not be aware of. There are so many concern about the fasting and postprandial HbA1c values that they forget the foot and they don't examine the feet properly. So examining the foot in each visit has to be done.
Wonderful, sir. I think you have highlighted that, and it is so simple. It is not something that is so complicated.
Yeah,
And
very simple.
majority of our Indian population, we all are walking barefoot most of the time, and quite often they in quite hot climates when they go out, they're still barefoot. I think just looking at the feet, you have kind of made saved that person's you know. Uh, the whole complications, preventing the complications just by examining the feet. You don't even need to touch it so many times. You can just see, and then you can pick out all these aspects, as you mentioned, calluses, cracks in the feet, and then deformities, all of this just by simple examination. So wonderfully put, sir. I think now when we look at other risk factors, as you already covered, poor glycemic control, any deformity, arterial disease, just by looking at peripheral pulses, I think we are able to cover all these things in order to prevent these complications. Now let's look at uh, what are the pathophysiologies that we need to focus on, especially when it comes to diabetic foot ulcers. And can you delineate any of these common anatomical locations that you commonly see in your practice? Do you see that more on any part of the foot you see more common in your practice, or it's like most of the time it is
The
pretty
anatomical
straightforward
locations which are more common are usually on the foot,
areas?
and it can also occur both in the plantar aspect and the dorsal aspect, but in the plantar aspect, the chances are more as compared to dorsal aspect. Now, what happens when we see these kind of foot ulcers? Many a times patients do not remove their footwear, so it becomes very difficult also. So I think in each visit we have to properly examine, and what we see that sometimes associated fissures or cracks in between the toes is also important, because these are the locations where a lot of fungal infections can be there, and they will invite further diabetic foot ulcers. So callus, corn, which are invariably more on the plantar aspect. So properly examining the feet, and we have to also see the temperature. We have to see other changes, such as whether there is any autonomic involvement, such as dry skin or absence of sweating, loss of hair. So they can be present anywhere, not only in the, but more overall. If we see most of the patients from my clinical as a practice, I have seen that the ulcers are invariably more in the foot or weight-bearing areas, especially on the plantar aspect of the feet.
So, excellent point, because today only we had one case where if I didn't see the foot, this man has uncontrolled diabetes for a long duration. So he came for the first time, and as you said, we have to make it a important practice every time a patient comes, new, old, anything. You have to look at the feet. So he has neuropathy for a long time, loss of sensation, and there is an impending ulcer. If I had not seen that, again, we would have, we could have
It
led
would
to
have
a
been
severe
left undiagnosed, yes.
undiagnosed. And what 50% of these impending ulcers, once they get infected, 50% of them have a chance of getting infected, and 20%, almost 20 to 25% is what the amputation, what we are seeing commonly. If you look at people who end up with these ulcers who are uncontrolled, they end up with an amputation in the end of the day. And so that definitely adds to that challenge that is there. And a simple thing, by looking at the feet, it makes all the difference. So there are many guidelines also. So many guidelines. Do you believe in guidelines? That is my first question. Do you believe in guidelines? Or I think
Guidelines, they help us in having an idea, but it is not possible to directly and strictly follow these
yes,
guidelines in each and every patient, because every patient is unique. So
yes,
one guideline may not suffice, or may not serve the purpose for all the patients. We are now in an era of precision diabetes, where every patient is different. Uh, we need to treat each and every patient differently. Of course, the guidelines are required because they can guide us in the correct path and can help us navigate these patients and treat them in the right manner, which we have to address these diabetic foot ulcers. But as I've said, every patient is different, so we can, keeping that guidelines in mind, we have to also look for other factors which are also equally important, especially glycemic status, then whether they have these risk factors for diabetic foot ulcers, then how is their gait, how is their weight bearing areas, so do they have some other associated deformities. So all these points have to be kept in mind, though guidelines help us, but again, when it comes to treatment, I think we also have to use our clinical judgment.
Very true. I think it gives you a structure. I think in our Indian scenario, when we are seeing so many patients, the volume of patients is so large. We have to be smart about how we are dealing with our patients. We have to be thorough. So definitely educating ourselves is something that is extremely important. So every year, if something new has come in, some classifications with regard to how we are looking at these ulcers, it can simplify your work, as well as it can also tell you what to do next as well. So guidelines, I think looking at Indian guidelines is extremely important. Whatever Indian studies that we have, and we have Indian guidelines, it is extremely important. So now moving on to our next question, sir. I think as you had from the start and till the end of your presentation, you were very clear about glycemic control. And what do you like? Do you rely on A1C? Do you use the help of CGM? Do you tell your patients to monitor more frequently SMBG at home? How many of your patients actually they come back telling you that yes, I've checked very often? So glycemic control is important, but how do you deal with this challenge of seeing what kind of control your patient has in between the visits?
So this is we advise our patients to go for SMBG, but not all patients do follow. At least 30-40% of the patients do this SMBG now. Now there's a new device also, the ambulatory glucose profile, which makes it even more easier. You just attach the chip and then you can monitor you can get an idea of the blood sugar every 15 minutes for the next 14 days. But now I think over the last few years, where we have seen that the awareness has increased, so now patients have started using these glucometers and more frequently than what it was 10 years back. So they do monitor their blood sugars if we advise them, if we teach them, because this also helps in titration of the doses, especially those who are on insulin, because every time one fixed dose may not be sufficient. You need to do these modifications, and we also have to educate these patients about the importance of doing their SMBG or doing this glucose monitoring in their home. AGP does help us also a lot, but not all patients can afford AGP, especially in rural areas. So this is one important point. But what really is important, that they should be aware that keeping the blood sugars under control is required to achieve or to get proper wound healing, because that is important. And the glycemic goal or the HbA1c again will vary from patient to patient. So for a young patient, we'll try to be very stringent and we'll try to keep it around 6.5 to 7. Now a patient who is old, who has got multiple comorbidities, reduced life expectancy, around 7.5 or 8 may also be sufficient for him, because we do not want hypos also. Then patients with multiple comorbidities, having renal issues or liver issues, for them again, the glycemic control or the glycemic goal is different. So since every patient is different, we have to set the HbA1c target separately for each and every patient. Most importantly, I believe that now the glycemic excursions or glycemic variability should be less. The time in range concept has also come up, and that is why we now want most of our patients to be in that time in range. We do not want hyperglycemia. At the same time, we know that hypoglycemia also has its deleterious effects. So just monitoring the HbA1c alone is also not sufficient. Now the newer concept of time in range has also come, where we want most of our patients to have less glycemic excursions, less glycemic variability, so that at the end of the day, these patients who have less glycemic excursions can have less complications, and not only foot ulcers, any complications chances can be reduced with this proper time in range concept.
So
Oh,
I
okay.
think, yeah, definitely, it's a big challenge. I think more and more we have to educate our patients, and focusing on that point of education. um, I think it is when you're seeing probably 50 to 100 patients in an OPD. How have you, I think now with the help of social media, these videos that we are creating here today, so how have you, uh, what are the things that you have incorporated into your practice where you are, educating your patients about diabetic foot care? And so what can you highlight on these aspects?
Now, preventive strategies, first of all, proper foot care has to be done. That is why we educate our patients that even a small, first of all, they have to do the examination, because though we examine the feet when they come, but we have to teach them how they can examine their feet at home using a mirror, or making or taking the help of another person. But what is also equally important is that we should ask them to avoid walking barefoot, which most of our Indian patients do. Then, if there is any callus or any corn, they should not do any home surgery. Many patients also do their try to remove them with some indigenous things, with a knife, or with a razor, or a blade, or any pointed object. So these homemade surgeries should not be done. It should be completely stopped, and we should educate them that if you find any kind of such things, then you should immediately consult with your doctor. Then, regarding the preventive strategy, proper footwear also has to be done, because many times what happens, we see that patients wear very good clothes, but their footwear is very inappropriate. So, especially if the patient already has an ulcer and he is wearing a bad footwear, then what happens is that the ulcer will not get proper offloading. So, it will be constantly under pressure. So, the wound also will not get proper healing, or will not heal in the correct manner or in the right time. So it will take more time to heal. It will be continuously under pressure. So foot with a wide toe box should be advised, so that there should not be any crowding of the toes. Then they should preferably buy their footwear in the evening, because this is a time where sometimes those who are at chances of having swelling feet, the foot swells more in the evening. So buy a proper size footwear. And socks also patient should wear, but without any seam or elastic, which is again required. And now customized footwear is widely available around the country. Most of the places there are customized centers where you get customized footwear. So one footwear may not be sufficient for every person. So based on that, you can ask your physician where you can get a customized footwear.
So moving
So
on,
based
sir.
on these, we have to.
Yes. So, I think you've highlighted very, very important aspects when it comes to educating, not only, first of all, reading guidelines, educating ourselves, on updating ourselves on how to take care of this big challenge, is also educating your patients at every visit, talking about offloading, using the right footwear. Now let's move on to, if I was in your practice. Now we are going. If I'm a young doctor, what is your advice? What are the equipments do you think we need to have in our clinic? Basic equipment, and what are the advanced tests do you feel that is required for us to, go into details of diabetic foot evaluation?
Now, first of all, in the clinic, you have to first of all have a proper foot examination. Then for that you need the monofilament to see the vascularity. Then you need a tuning fork. So these are tests which requires. Then there should be some other important tests, such as the Doppler test should be done, ankle brachial index test that has to be done. So these foot pressure study, because we should know which part of the feet gets more pressure, so that Harris-Met, that foot pressure should also be assessed. So these tests should be done to assess the neuropathy, to assess the vascularity, because sometimes just by simple examination of the feet, you may not get an idea as to what is the root cause of these foot deformities. So in our day-to-day clinical practice. Temperature sensation also has to be tested. So these are tests which are routinely done in a good setup, and this can be of great help in understanding the etiological factor behind the development of diabetic foot ulcers.
So now moving to the final question, sir. What is your advice on nutrition? What do you feel, how nutrition can play a part, especially when it comes to dealing with food complications, dealing with individuals who have ulcers? Quite often, the kind of food, majority of them are taking unbalanced, only carb, lack of protein. They already are dealing with muscle wastage. So quite a lot of their immunity has come down because of the chronic conditions that they're dealing with. So what is your take on these points, sir?
Now, I think it's very important that proper nutrition has to be there. Now, we know that in a country like India, where most of the patients do favor, or in spite of the best of the advice, they will take a lot of carbohydrates. So we have to advise them to reduce the amount of carbohydrate. Low fat diet is very much required. And if required, and if options are there, takes help from a good dietitian, because the nutrition has to be assessed based on your body weight, based on your glycemic status. Now, how much calorie you need will be again different. So every patient is unique. So proper balanced diet with timely intervention requiring the appropriate calorie, which is very much, we have to understand how much calories required for this patient, because most of the patients, what happens is that they consume huge calories. And we also have to make them understand about the importance of fiber, because fiber consumption is very less. Reduce the intake of carbohydrates, take more of proteins. And we also have to advise most of our patients to avoid this junk food, saturated fats, which are now easily available everywhere. So taking a good balanced nutrition will be helpful not only in controlling the sugars, but in preventing these diabetes-related complications which is there. So taking advice from a dietitian is what I suggest to most of my patients, because a dietitian gives them a customized diet chart. Now, whenever we advise our patients regarding nutrition, we also have to keep in mind what kind of food they like, their likes, dislikes. We cannot impose everything to these kind of patients. No, we also have to keep in mind their likes, their dislikes, and what is their food pattern, which part of the country they belong to. So every region has a different food pattern. Every region has a different food culture, food habit. So based on these, I think a customized diet pattern, well-balanced diet has to be given, because unless and until you have a good nutrition, I think the healing also will not be adequate, will not be sufficient, and the glycemic control will be very difficult. So having a proper nutrition is actually very much required, and this is why customized diet charts should be given to each and every patient.
Excellent, Dr. Pranab. I think you covered everything, but I have one final trick question for you, sir. So there is Rajasthan Royals, Kolkata Knight Riders, and Hyderabad. Sir. Which is your team? Which is your team that you want to see lift the cup?
I think I'll go with Rajasthan Royals this time, because they are doing quite good. Though they should have been in the second or first position in the playoff groups, but they finished third. But I think yesterday they played very nicely. So let's hope. What is that? We hope we have a good match without any rain interruption, because that really distracts the crowd, and that really makes things look very worse. So without rain, if we have a good match, I think the crowd will really enjoy.
Excellent, sir. I think you covered all the topics very well, and whoever is listening today would have surely learned a lot about diabetes foot and diabetes foot complications. So thank you so much for tuning in, and see you next time. Thank you, Dr. Pranab. Thank you, sir.
Thank you. Bye.